Thank you, Dr. Rowley, and thank you to the IOM for our invitation. At the California Maternal Quality Care Collaborative, we live in big data. California is over 500,000 births, some years as many as 550,000 births. And we're trying to evaluate the quality of maternity care in over 280 hospitals and other settings. The types of data we work with are both administrative data and the merger of clinical data sets. In terms of disclosures, I do not have any financial disclosures. I do supervise quality directly for 20 birthing centers in Sutter Health, including 2 of which are in which the majority of births are by midwives. I also provide as a maternal fetal medicine specialist outpatient consultations for several hundred Northern California maternity providers, including midwives and freestanding birth facilities. We're going to discuss how to use data for the analysis of these types of issues, and it is not going to be easy. The limitations of vital records, the denominator and numerator difficulties, power limitations, and comparison issues that have come up all day yesterday and already today. One of the keys is what is high risk. That's been poorly, and who high risk for what, and then how to compare different groups at their risk level. Then we're going to end with a discussion of what we're using in California for ongoing assessment of hospitals, the 98% of births that happen in the United States. We've talked a little bit about the limitations of the U.S. standard birth certificate. Not only does it not identify the intended place of birth, but it's a critical issue for transferring, because the transferred group of patients does have a much higher risk of serious morbidity. Certainly that's what we've seen in Northern California. And that means there's less morbidity recorded for home births and more for hospital births. And specifically, Bill showed this, the non-specific, that is non-specific in terms of identification of transfer. When you actually look at the instructions on this page from the birth certificate, it really does focus in that this is about transferring mothers from facility to facility and not from home to hospital. In a sense, that's a very difficult question to ask because most mothers come from home to a hospital, regardless of whether they were intending to deliver at home or not. So that'd be a very difficult one to capture in general. Even a revised birth certificate, as suggested, has a number of potentials for error. It may look good to have things written down on the birth certificate in a perfect way, but it still has to be completed correctly. And that's a big issue. There has been little attention paid to actual birth certificate quality in the United States. That's something we're working on in California. We have a big project that has started with the Revitalize Movement project, which is a multi-stakeholder effort to standardize definitions from all obstetric providers, and all the organizations represented in the room have been involved with that, and that will be coming out later this summer, actually. So that's a beginning step, but there needs to be data feedback and quality assurance about the clinical pieces on the birth certificate. And that's what we're starting in California. Having said that, though, the, quote, minor or less significant fields are going to be subject to a lot of question, such as some of the ones we've been talking about, because they are rarely used. That means the birth certificate clerks are going to be not very adept at asking or completing those questions in general. And anything that's new in a birth certificate needs several additional years to roll out and to actually bring into play, and still is subject to some of the accuracy issues talked about before. Okay, now, all day yesterday we talked about small numbers. And to the small numbers, particularly around perinatal mortality, neonatal deaths. In these kinds of settings, it's about 1 to 2 per 1,000. Power calculations, if you want to show differences even at the level of 1, that's on the order of 23,000 births in each arm. Total number of home births in the US is 27, now 29,000. So we have struck power issues, difficulty issues, if we're looking for small differences here. Likewise, if we're looking at perinatal mortalities and 1 to 2 per 1,000, we have numerator issues. Okay? If, for example, a sample size that we're looking at is 10,000, that's only 10 to 20 cases for 1 to 2 per 1,000. So that misattribution makes a very big difference here. You move a couple of cases, a handful of cases from one population to another, that changes the whole calculations. So misattribution or non-reporting of cases can be a big issue when you're dealing with these kinds of numbers, both the requirement for big denominators and the requirement for really accurate numerators. It's sort of a principle here when you're dealing with perinatal mortality and some of these other issues it's a Heisenberg uncertainty principle at play here. You can either have big numbers, i.e. birth certificate, or you can have super accurate data, but you can't really have both. And that's a struggle that we have to live with these kinds of analysis. To have a really high quality issue for the numerators, it requires ongoing extensive focus on these data elements, and that's dollars and time, and still we may have difficulties with accuracy. So the birth certificate data is something we've looked at quite extensively in California. A number of published studies have analyzed the accuracy of the birth certificate. And there are some birth certificate data that is very good. High accuracy for the birth date, time, birth weight, parity, which is a very important one, not available in many other data sets, plurality, which is number of twins, triplets, et cetera. Demographics, race, and ethnicity are very good on a birth certificate. The method of delivery is actually very good here. Others that are acceptable, not perfect, but pretty good, is the OB estimate of gestational age, not LMP estimate. Most birth certificates have both. And many centers are moving toward using the OB estimate as a much tighter distribution curve and a more accurate estimate. But the ones that are known to be poorly collected and represented are unfortunately many of the ones used for risk adjustment. And those include pregnancy complications, L&D complications, neonatal complications, and NICU admission, which are on our birth certificates and look good, quote, on paper, but they're, by the time birth certificates are usually filled out either within hours of birth or certainly within a day, and a lot of the neonatal information is just not known. And in culling for complications in the pregnancy and L&D is sometimes beyond what the birth certificate clerk is best at doing. However, if they are there, they're usually accurate. And so there's a high degree of accuracy if they're there. But this makes it hard to adjust for medical factors solely on the basis of the birth certificate. So this is a study that just came out from Oregon that was presented about a month ago at the Society of Maternal Fetal Medicine. I don't want to look at this in terms of the data itself, but it shows some of the issues that I just discussed. Here they have gone through and compared three different ways of looking at hospital data versus the planned home birth in Oregon. It's 3 years of data, 2008 to 2010, and it looked at, so group C is the typical hospital comparison group, all near-term or near-term births. Group B is reduced by excluding facility transfers. They thought initially that they were going to exclude intended home births, but almost certainly they did not. And then Group A, as we're moving forward, is further reduced by applying the Oregon eligibility criteria. Oregon does have some, actually in their state regulations, eligibility criteria for home births, which had a series of exclusionary factors. So if you excluded those from the hospital level, hospital data set, you get a very different comparison numbers as you go through these groups and come to very different conclusions. Now, difficulty here is this is 2,000 home births. Okay? And what did we just say about denominators and numerators? This is 7 neonatal deaths. entirely in that population is what that calculates to be is 0.26%. So we said a couple this way, a couple that way changes the whole conclusion. And you just can't do it with this kind of data. So what we have is a problem. We like single state data because that's at least reasonably same rules or regulations on populations. But even this one state that has one of the highest rate of home births in the United States, Oregon, it took them several years and they still only had under 3,000 home births. So they don't have appropriate denominators. But different states will have very different home birth certifications, guidelines, and cultures. So and even that can be different within states. So it's hard to do that, roll those up. And then, as we discussed, if you're just looking at birth certificates, it's hard to look at just the coding. Were they undercoded on the home births? Were they undercoded for the hospital births for maternal complications? Oregon did change their question about intended home birth as of January 1st, 2012, but it remains to be seen how that's really going to roll out in terms of how that will be completed at the hospital. Okay, so we have this dilemma that we need very large numbers for denominators, and we have to be very careful about not under-reporting numerators. And we need, particularly as we look at the Strong Start program, more robust sources of medical complications to do the risk adjustment or risk stratification. The birth certificates can provide the denominators. That's very clear. All births are recorded in the United States. Linked data sets are going to clearly need to be used to provide better information on medical conditions. But we still have issues with numerator identification. And I don't have a good answer for that. So let's talk about Strong Start for a moment and how actually comparisons is appropriate for all the issues we've talked about for all the birth settings. If we cannot randomize, how can we make groups more comparable? And obviously, needs to be some control for medical and demographic factors, and some of the social issues that was spoken by Caitlin in a moment ago. So let's commitment to home versus hospital for birth centering or birth center or centering pregnancy. And what would be a very interesting question to get at some of these more attitudinal issues is, what is your commitment to a vaginal delivery? Okay. That varies a lot among women in how they help choose a birth setting. And that might be a simple approach to that. When you look at the IOM risk factors for preterm birth, that was published several years ago, that is the basis for Strong Start, that's showed here. This is a grab bag. Okay, it's anything that's ever been really reported in association with preterm birth. When you look at some of these, though, some stand out as really high risk factors here in pink. If you've had a prior preterm birth and you're Black, your recurrence rate is about 50%. If you're white, it's about 25, 30%. That dwarfs the recurrent preterm birth risk of almost anything else on the screen. Likewise, except for multiple gestations, and I would say that you have to look at those entirely separately and probably shouldn't be in the analysis at all. Placental anomalies, it depends on what it is. Current IUGR, which is not a pre-existing factor, of course, is a significant risk. Early onset preeclampsia, there's some that are, they've excluded low SES because of the population. And if you have no prenatal care, you're not going to be in it, but that's a significant risk factor. Methamphetamine is the drug that's now of importance, not marijuana, for preterm birth. And so it gets to the importance of that risk factors, some risk factors are more important than others, but there's also a point that these are not dichotomous, not yes, no. And it really is a matter of gradations. And the gradations in particular are illustrated here. degree of hypertension. You could have a history of hypertension and be coded that way, or have mild hypertension, not on medications. That's very different than someone's on medications, particularly 2 medications in terms of risk, et cetera. Obesity, obesity is defined as a BMI over 30. Half of US women at least are over 30, but not that many are over 50, and that's probably where the risk is. Anemia can be anywhere from low 20s to low 30s, they're very different risk profiles, but it's going to be coded the same. And likewise with maternal age, 30, 35 is very different than 45. So you have to have some ability to judge gradations within the risks. So the plea here is that risk adjustment needs a lot of work. You need to simplify it, probably fewer factors, but then make it more complicated by looking at those effects and interactions. Now, if you look at labor outcomes, though, and these are some of the typical labor outcomes that are proposed in many outcome studies, the single most important factor here is parity. And that has to be a dominating factor in any risk adjustment. As we saw yesterday with some of the birth outcomes in England, null-eps first births have the greatest difficulty. And that's true of no matter what the birth setting is. That's why we've chosen to focus on first birth C-sections as a quality measure throughout. And that's actually the Joint Commission quality measure now. And it's about your first birth. Once you've had a baby successfully, it's hard to find a lot of risk, no matter where even in a taxi. Okay, if you deliver on your way to the hospital in a taxi, those babies almost always come out screaming. We've covered some of these issues already in terms of we really want to. One of the key factors, the biggest factors, is the African American populations that may or may not have low risk medically, but we may want to separate out the demographic factors separate from the medical risk factors. So what we have for vital stats is continuing issues with attribution and accuracy, not such a good source for comorbidities. The patient discharge diagnosis file that every hospital submits in the United States to some entity, and that varies from state to state, is actually a pretty good source for comorbidities and complications, and it's easily linkable to vital records, and we're going to show that in California. But it's not collected for home births or even for birth centers, because this is a hospital discharge diagnosis set. We are doing data QI projects in play for both of these data sets in California. The registries, as Bill said, are not universal, non-standard, and they're voluntary, and that really does raise questions. We hope to have those be mandatory, and I applaud those who are doing quality on data regardless of the site. That really has to be done. So you're left with research data sets. Those are expensive and probably not going to get your denominator size just because of the time and expense. I'd like to spend 1 minute on understanding small risks. That's what we've been talking about, small risks. And that's a big issue for many of our patients. And people have a hard time understanding small risks. In prenatal diagnosis, we have women who are, when you are assessing them for Down syndromes, that are unwilling to take a 1 in 10,000 risk, and others that are very happy with a 1 in 150 risk, or even a 1 in 50 risk. So the take-home point here is that women and family have different assessments of risk, and that's going to make a big play as to how they interpret the risks in a birth setting, among the different birth settings. And this is not an objective external way of analyzing. This is an internal family judgment. So an editorial here is what is driving the increase in home births? And it's really, I think, clear to me, talking to women in Northern California at least, that it's a fear of over-medicalization of birth with too many interventions. This is just the C-section rate, induction rate, and varieties all follow. And the timeline is contemporary here. It was going down as the C-section rate was going down. It's gone up after a couple-year lag as we see this. Not to mention the near disappearance of VBACs. So the women have fewer choices in hospitals, and so they're looking for alternatives. I'm going to end with a couple slides about the 98% of births that occur in hospitals. My take-home point here is going to be that not all hospitals are the same. We can't lump them together. It's like we had a lot of discussion about lumping together different types of midwives. This is California date on nulliparous term singleton vertex C-section rates, the Joint Commission in Healthy Person 2020 measure. That's in blue, total C-sections in red. This is 12 regions, 11 regions in California, each about 40,000 births. California is about 10 states worth rolled up. And there's huge geographic variation here. With NTSV C-section, the national goal for that is about 23%. My region in Northern California is down around 21%. LA is over 30%. What we have put together was a data center in California that puts together administrative data sets for data quality and for clinical quality improvement projects by linking on the fly birth certificate data that the state gives us 45 days after the close of the month, every month. So it's fresh data together with hospital supplied PDD or ICD-9 codes. So we link that on the fly with 99.8% completion, and then can calculate a series of data quality measures and clinical quality measures, and are currently calculating the full range of NQF measures and the Joint Commission measures. This is a screenshot. It shows what we're just the types of different measures you can do, both the clinical quality measures, general statistics. This is just the lead-in page, so we have a lot more hiding. And then shows timelines comparing yourself to the state or to other in your region or like hospitals. This is the NTSV rate on every hospital in California for 12 months ending in 2012. You can see just a huge amount of variation. Huge amount of variation, all the way from some that are down to 10%. Remember, I showed you regional levels, which rolls up of groups of hospitals. This is actual hospital level data. 10%, this is, these numbers are hospitals that have very few births, so it's a little skewed, but there's a number of hospitals that are 40, and a number of hospitals that are 10 or 20. So you can't roll them all up together. So I'm going to end, and this is a rhetorical question. Okay? By saying when you have variation like we see, there's opportunity to say, okay, we should pay based on outcomes, wherever you are. I think that's the segue into our next segment about payment reform. So I'm going to end with that. Thank you.